everyone, I had a clinical case recently that made me consider exploring the literature around antifibrinolytic therapy for the management of post-surgical hemorrhage. I started to write an article exploring the use of them and realised a good friend and colleague of mine is more widely read and published in the area than myself, and therefore I realised she was the best person to ask the question to. And she's kindly agreed to speak to me. So Rachael Birkbeck is a diplomat of the American College of Veterinary Emergency and Critical Care, currently working in private referral hospital in the UK. She's published an extensive review article on hyperfibonolysis in the Journal of Small Animal Practice, and therefore I think she's in a good position to discuss the possible use of antifibrinolytic therapies in this dog. So thanks for joining me here today, Rachael.
Hey, welcome.
It's great to have you here and hear your pearls of wisdom from your various extensive literature search.
I was just thinking, Laura, it's kind of funny because when I first started the residency at the RVC, I remember doing evening rounds with you, Stefano and Tom, and I was like a newbie on my first shift, and you kind of had your like edgy haircuts and looked really cool, and I was trying to impress you. And I remember you saying about whether or not a patient had had a TEG. And at the time I was like, bloody hell, what on earth is a TEG? I've never heard of this thing before in my life. So I wouldn't have thought or predicted that we'd be chatting about it like 4 years later. And potentially maybe I know a little bit more about you than you about it, but I'm not sure.
Yeah, I think you do. You're on my like speed dial for anything to do with a coagulopathy and fibrinolysis.
Oh, don't know. Anyway, let's see. Hopefully I'll be able to give you a bit of help with this one.
Yeah, so if I tell you a bit about the case, it was a 5-year female entire Cocker Spaniel who underwent surgery for anal sacculectomy and sublumbar lymph node removal, as well as the ovohysterectomy while they were there, after a diagnosis of anal sac adenocarcinoma based on fine needle aspirate, and had CT staging. And other than having quite considerable ionized hypercalcemia preoperatively of 2.39, she was relatively stable, pretty stable, and this was managed medically pre-op. Hematology was completely normal PCD, total solids. So she went to surgery, and according to surgeons, went as expected. So she had the ovohysterectomy using like a bipolar sealing and dividing device, anal gland sacculectomy, and then obviously, divert to surgical colleagues, but there's the various major vessels in the area. So, medial iliac, left internal iliac. And they just describe how they kind of, bluntly dissected, the lymph nodes in that region. And they described that, which I thought was interesting. They showed me some images that they report these surgeries always ooze intraoperatively, but describe it, and they never feel that they can manage all the oozing, but it's not unexpected, and they were happy to finish the surgery and close the dog up, and not thinking it was anything out of the normal of any other surgeries in the same vein. Anesthesia, thought she was a bit hypertensive under GA, so required about 20 mils of kilo crystalloid bolus, and then she comes to ICU for recovery. And that's kind of when I saw her, and she developed this worsening tachycardia. She had pale mucous membranes, very hypertensive, and underfilled left atrium, consistent with like hypovolemic shock. Fluid score, interestingly, on like scan was about 2 out of 4 sites, and her PCV pre-op was 45%, and then total solids was 55. And post-op 30 to 34 grams per litre. At this point, we'd given her a few extra crystalloid boluses post surgery while getting our coagulation profiles. We got PT, so prothrombin was 23 seconds, ranging from 11 to 17 on our reference range, and then APTT was 145, so ranging from 72 to 102. So, mild elevation, but not really pushing, kind of 1.5 times. And platelets, they were about 3, 4, 5 per high power field. And then, given her a few extra crystal bolus, so 20 ml per kilo, and then decided, based on the fact that she was oozy, would give her some fresh frozen plasma. And so she had kind of 2 units of fresh frozen plasma, so about 20 ml per kilo. But she, a bit like still hemodynamically unstable, and the fluid within the abdomen appeared to increase in size, which is again quite subjective. But the decision was made to take her back to surgery. Mm-hmm. And the surgeons didn't find the Explore very fruitful. They described kind of some persistent ooze from the sublumbar lymph nodes. They kind of packed further, but there was not sort of a vessel bleeding. So they kind of had to pack the oozing, and they tried to like en bloc remove some of the muscle. She had an autotransfusion intraoperatively. And then even despite this surgery, for the next kind of 24 hours, she was persistently tachycardic. She required further blood products, so had a packed red blood cell transfusion. She received more plasma, ultimately accumulating in her and having a massive transfusion. And I think one question that arose when we had kind of been reflecting on this was, whether antifibrinolytics could have been considered as part of her management. And this is kind of where I wanted to get your thoughts on.
Yeah. So I suppose maybe we should just recap initially what fibrinolysis is. Would that be helpful? And then we can kind of go through why it might be beneficial to treat hyperfibrinolysis in this patient. Yeah. So what would be your understanding of physiological fibrinolysis?
So I guess, for me, it was always that part of coagulation that they never really taught you, they always kind of missed that part off the, your coagulation cascade. So you need to obviously form a clot when you bleed. What I understand by you form a clot, but then you also have to break down that clot to kind of restore patency to the vessel once the the insult has kind of passed.
Yeah, I mean, the way I kind of think about it is actually, I think you're right in terms of you have your primary hemostatic plug where your platelets are there, and they're kind of activated by subendothelial collagen if that's exposed when you get tissue injury initially, and then potentially von Willebrand's exposure as well, and then tissue factors exposed from your endothelium, and that can kind of trigger the coagulation cascade and the formation of thrombin. And then thrombin will essentially be what will convert fibrinogen to fibrin, and fibrin will help to bind all your platelets together, and also throw in some red blood cells and bits and pieces in there too. And then eventually you'll get sort of a fibrin stabilizing factor, which will cross-link your fibrin to make it really structurally sound. But then I always I guess it's not intuitive to think of this happening, but fibrinolysis is activated concurrently with coagulation. So at the same time, when you get this vascular injury, you're releasing sort of in the vessels and the vasculature tissue plasminogen activator, which is going to convert circulating plasminogen, which is sort of relatively inactive, into plasmin. And then I think you're right. The way to think about it is that you want to form a clot, but you want that clot to be localized to the region of vascular injury. So you don't want it to just grow and grow and grow. And so it will kind of make sure it's contained. And then also when it's more appropriate, it will start to break down that clot, so that you can get, you won't have disruption of your microvasculature and your blood flow to tissues. And essentially the balance between activation of coagulation and thrombin production, and then plasmin production as well, secondary coagulation and fibrinolysis. The balance between those two things determine whether you're going to be potentially prothrombotic or have a bleeding tendency. And usually they should be nicely balanced so that actually everything proceeds. Normally you produce a nice clot and you break it down when it's appropriate. I don't know if that makes sense, but that's kind of my way of thinking about it.
Yeah, I think that yeah, it's nice how you put it. I've never really thought about, like you said, it's all happening simultaneously, and it's not just, oh, it needs to activate at the end to restore vessel patency. No, you need it there to kind of limit, like you said, clots, um, um, to ensure the clot is kind of localized, which is yeah, something that I kind of haven't really properly considered. So that really makes sense.
And then I think like in your vasculature, it's normally like tissue plasminogen activator that's going to be the main sort of player. But then more so in your tissues, I believe like urokinase type plasminogen activator, so like UPA, is more predominant, and that's kind of like the one that's a little bit more interesting when we get on to like talk about neoplasia, because it maybe has more of a role in that sense.
And so I guess you're saying you want this balance between, clot formation and clot breakdown. And I guess the clot breakdown we're saying is fibrinolysis.
Yeah, exactly. And then like so it is appropriate to break down your clots, otherwise we'd all be just like walking around for about 5 minutes before we died, because like none of our tissues would ever be perfused. But equally, if you have, so that would be like physiological fibrinolysis or fibrinolysis, however you pronounce it, but physiological, just like it's normal and it's appropriate. But if you have hyperfibrinolysis, then that's when that process is sped up. And the reason that that's problematic is because you haven't had the opportunity to heal whatever vascular injury was initially present. And so essentially when you remove that fibrin that's stabilizing your clot, you lose the clot, you lose the kind of plug, and therefore you get hemorrhage. And that's why it's problematic.
And yeah, that makes sense. If it's governed, you're saying that this kind of tissue plasminogen activators, TPA, it governs the kind of rate of fibrinolysis. And you mentioned like conditions that kind of this can occur. So hyperfibrinolysis has been kind of documented in, and yeah, kind of why we think that is.
So there's like a couple of things. So I guess one of them is like trauma that everyone I think is becoming more familiar with. And then in like horrendously injured people who've had like awful trauma, essentially they can be massively hyperfibrinolytic and also hypocoagulable within the first sort of couple of hours. And that really comes down to the fact that with coagulation, you've got activators and inhibitors of coagulation and also of fibrinolysis. And so to make sure fibrinolysis is not proceeding completely unchecked, you've got a number of inhibitors of fibrinolysis that will kind of float around in your bloodstream. And so you've got plasminogen activator inhibitor, you've got alpha-2 antiplasmin, and then there's a couple of others, but those are kind of like the key ones. And essentially, like if fibrinolysis was massively activated and you had a huge amount of TPA or UPA released and lots of plasmin being produced, then you could kind of understand that you might get to a situation where the normal inhibitors of plasmin are overwhelmed, and so that means that plasmin can kind of just run riot, breaking down fibrin all over the place. So in people that have had huge trauma, then it's sort of really extensive damage to their vasculature from like the traumatic injury itself, but then also sort of endothelial activation because of shock, catecholamine release, hypothermia, like all these other contributing factors can cause like huge release of tissue plasminogen activator. And also at the same time, like coagulation will be activated, but it just kind of depends on the balance of the two. But you can get situations where so much TPA is released that you get a lot of plasmin being released as well. And then your normal circulating inhibitors of plasmin and of therefore fibrinolysis are completely overwhelmed. And so this is why like within the first maybe like 4 hours of trauma, the use of antifibrinolytic drugs can be really helpful, because essentially they can inhibit fibrinolysis because you no longer have that natural capacity to inhibit it yourself. But then there's a couple of sort of studies that have shown that actually a little bit later on in the course of your trauma, if you give antifibrinolytic drugs, potentially that can worsen outcomes. And one of the proposed reasons for that is that actually PI1 or plasminogen activator 1, which is one of the main sort of inhibitors of fibrinolysis, the body is clever and it kind of realizes we're in a bad situation, and then the production of PI1 is upregulated by the liver, and so actually you catch up, and within sort of like 4 to 6 hours time, it's been shown that your sort of circulating levels and production of PI1 is increased, and so your body is trying to compensate for like this increased utilization of inhibitors, if that makes sense. And so yeah, I think it's a really dynamic process, and it can change from like minute to minute, hour to hour, and it's all kind of related to like the balance of activators and inhibitors in your bloodstream that can change depending on the situation.
Yeah, no, that's super interesting. So, I guess to recap, because I always find like the acronyms and all the names, they all sound so similar.
Yeah, it's tricky to remember them all.
And they just roll off your tongue. So, tissue plasminogen activator is that kind of TPA.
Yeah.
Is activating plasmin.
So plasminogen to plasmin, and then the plasmin is what is going to break down fibrin.
Yeah, and then when there's PI1.
Yeah.
Remind me what PI1 is.
So plasminogen activator inhibitor. So it kind of like does what it says on the tin. So it inhibits the activator of sort of plasminogen. And what did we just say activates plasminogen? Tissue plasminogen activator. Yeah. So I know, sorry, it's hard because they all sound really similar, but essentially PI1, plasminogen activator inhibitor, will inhibit TPA.
Yes, yeah. And that's, I think when you were saying about, there's that various kind of, the classic human studies, the crash tube study, and, give antifibrinolytics early, but then, if it's late, they can have more problems. And it kind of makes sense that your body is, like I said, it's so dynamic, and what's happening at one point doesn't mean that then that state persists.
Exactly.
We're probably just trying to catch up with what the body's like doing and like managing.
So I think like I kind of think it's easier just to consider like a couple of the inhibitors, and that's how I kind of remember it. But if you just think that PI1 is like one of the main inhibitors of TPA, and then if we get like massive endothelial injury or activation, you're going to get a lot of release of TPA, and you don't have like in that exact moment more PI1 being released as well. So it kind of like overwhelms that inhibiting capacity, but that's not to say that that is like a static situation, because you will subsequently upregulate. That's kind of the situation with trauma. And then with
Rachel, I missed that last bit, because you said so pi won't always be static, and then there'll be a point when PI1 gets upregulated. And just to clarify, the PI1 is produced in the liver. Okay, so then the liver kind of kicks in and says, hang on a minute, we've got excess TPA going on, we need to get this we need to inactivate it or push out more
under control. And I don't know how exactly that happens, like I don't know what the actual stimulus for that is, but I think it's it's been shown in a number of human studies that you do within like a few hours of trauma start to see like this increase in PI1, which I think is kind of subsequent to like an increased demand, and also because of utilization. There are like other conditions in humans and in our veterinary patients that are associated with hyperfibrinolysis as well. So like certainly there's like quite a bit of literature now in veterinary medicine with regard to like pleural and peritoneal effusions. And I always think this is really interesting. I don't know if anyone else does, but I do. And essentially, like, when you're like a baby vet and you're trying to do like your first pericardial effusion or like abdominocentesis, and you're like, oh my god, if I just like tapped a big blood vessel and getting blood or something, and then you get told to just like leave it in the syringe and see if it clots. And we've probably all been there, like turning up and down and just checking. And it, if you've sampled it from a body cavity, the it doesn't clot, and that's one of the ways you can tell you've done the right thing, and you've not sampled from a vessel. And the reason behind that, I think, is interesting. So essentially, like, all of these body cavities are lined by mesothelial cells, and it would be a nightmare if you kind of had fibrin deposition within your pleural space or your pericardial space or your peritoneal space, because essentially, like, all of your organs would just stick together. Your lungs would not be able to glide, your heart would not be able to beat, and you'd just have like a huge mess of intestines. And so the mesothelial cells will secrete fibrinolytic factors. So they kind of are like constantly doing this so that you break down any fibrin that is being formed. And so that's like a normal physiological process. But if you have like huge, or like maybe not even have to be huge, but just if you have effusion build up, then you can kind of get this pool of fibrinolytic factors that then subsequently start to get resorbed into the circulation. So like your concentration of fibrinolytic factors are then like increased in circulation and can have systemic effects. So I thought that's interesting, because like the clinical side of that is like, yeah, you get this blood that doesn't clot, and then also conversely, when you've had a patient with septic peritonitis, they get these horrible adhesions. And the reason is because like you've got like such sort of diffuse damage to all these mesothelial cells within your abdomen, and so they're not able to perform their natural function of producing fibrinolytic factors, and so you get all this fibrin and adhesion build up. So I don't know, I just thought that was kind of cool, because it had like something that I could see happening in my patients. Yeah,
I think that is really cool. And I think putting into a really understanding like what we're seeing in front of us. And I think you've given two really nice clinical examples of being like, why doesn't it clot when you've got blood that's been sitting in a cavity? And then the converse, like, why do we see some like horrible adhesions in like cases of septic peritonitis? And I never really thought about it, that the mesothelial cells can't kind of produce their normal kind of anti-fibrinolytic protein. So that's definitely, I'm with you on that. That's pretty cool.
Yeah, and then I think like the one obviously like any like form of like liver dysfunction, I think it can really depend like what situation you're in with regard to your liver. But if your liver produces your coagulation factors, it produces inhibitors as well. And so like any sort of liver dysfunction could result in an imbalance of coagulation. And it might be that means that maybe you're actually going to have like a bleeding tendency because you've got clotting factor deficiency, or maybe you've got also deficiency of fibrinolytic inhibitors. So I think it can kind of be multifactorial in that respect.
I remember, I think, there's a few of those papers looking at coagulation profiles in like acute hepatopathy and chronic hepatopathy. Essentially they can do either or, hyper or hypo, and it's really difficult to predict, which when we're kind of taught in our kind of early years, like our undergrad training, it's like, okay, liver disease, you're going to be coagulopathic, and but it's a bit more complex. And I think understanding, as you were saying, like these kind of fibrinolytic proteins as well, like are kind of produced in the liver, then it might makes sense, because it all depends on that kind of balance again.
And then as well, like a lot of these disease processes, or like even trauma, most of them cause like inflammation as well. And then if we have inflammation and we have like endothelial activation, then you're going to get expression of tissue factor, which activates coagulation as well. So I think it's just really cool, because you don't really know what you're going to get, and it can be a bit of anything, and it can be you get one thing one day and then something else the next. So that's why I think it's interesting. And
this case, I was thinking, well, okay, it's got cancer, and I know, I guess there's some like veterinary literature on hyperfibrinolysis and spontaneous hemoperitoneum, which the majority of the causes are cancer. And I didn't know if I could like relate what I know from that literature to this case when it's not a kind of spontaneous hemoperitoneum. And I'd be interested to know your thoughts on like and I think you mentioned something which has got my ears pricked earlier about kind of urokinase and cancer.
Yeah, so I think like a lot of the studies, I'm really bad at remembering who's published what on what date. Sorry, it's going to be my dyslexia. But a lot of the kind of veterinary studies looking at fibrinolysis and I guess like cancer, I think they were more looking at animals with like cavitary effusions that then like of which neoplasia was a very common cause. So I guess in terms of like the association with our species or our patients between fibrinolysis and neoplasia, like you could kind of look at it, which is how I kind of compartmentalize it as like, okay, so do they have like a cavity effusion? Have they got like a hemoperitoneum or something? In which case, have they then got like this increase in systemic fibrinolytic factors, which could be contributing to them being hyperfibrinolytic? And then the other way to think about it would be kind of like independent of their cavitary effusion, or maybe they don't even have one. And that is kind of probably going to be like heavily leaning on like our extrapolation of what we know in human medicine, which is that a number of neoplasms, or I guess tumours, will produce activators of plasmin. So they'll produce TPA and UPA as well. And this is actually something that is kind of published most extensively in patients that have carcinomas, like mammary carcinomas, and then also men with prostate cancer as well. There's quite a bit of literature on this, and so I think I think the reason why, from what I've read in the literature, it might be beneficial for like a tumour to produce activators of sort of plasminogen to plasmin would be that plasmin has got like quite a few functions. So obviously we know it breaks down fibrin, but it can also activate like a lot of other, like I think metalloproteinases. So essentially these are things that can participate in the remodeling of tissues and like cancer progression. And so actually it might be beneficial for a cancer cell to produce plasmin because it has this other effect. And so there's like some pro-cancer functions of plasmin. So releasing like growth factors and also degrading pro-apoptotic factors as well, it's been shown to do, and also to promote angiogenesis. So I think that we know that plasmin will break down fibrin, but it has these other factors that would be beneficial for a cancer that was trying to grow and kind of spread throughout the body. So I don't know if you like have any thoughts on that one, but I think it's kind of interesting given that you said your patient had a anal sac carcinoma, is that right?
Yeah, exactly. And it's like, and
so I don't know whether like disruption of that could have potentially like resulted in some release of like UPA or TPA. I don't really know, but like it's certainly been like shown that like carcinomas are implicated in hyperfibrinolysis in people for that reason.
That's really, really interesting. Because I hadn't really got that far in my thinking other than, I know that, we all like to kind of use, antifibrinolytics and, but just thinking, extrapolating from purely the studies in veterinary of spontaneous hemperitoneum, and I hadn't really thought about, it's nice how you kind of compartmentalize it and said, right, okay, so there's, not necessarily the cancer that's causing the hemperitoneum, but the process that you've got, cavitary fluid can actually, lead to a hyperfibrinolytic state, and then, maybe cancer as well, but there's certain perhaps types of cancer that have shown to express more kind of TPA or urokinase or fibrinolytic proteins, which that's really, really interesting.
Yeah, and I think as well the other thing to kind of remember is like, well, I don't know, I always think, because I think we'll get onto this in a minute, but like one of the contraindications for giving sort of tranexamic acid or inhibitors of fibrinolysis is DIC. And I guess the other thing to always like bear in mind is like, DIC is a huge spectrum in terms of like its, effects on coagulation. And actually, again, like in your patient, like, you know, I suppose there was a degree of like reduction, like thrombocytopenia, like I think you said, like the platelet count was reduced, and then like clotting times were like mildly prolonged as well. And you know, you can have DIC with like a pro-fibrinolytic phenotype as well, and there's a lot of like argument as to whether like one causes the other or vice versa. But I think just to kind of like bear in mind that, and I think you treated the patient with plasma, didn't you? So but
I always find it interesting. I'm sorry to like cut in there, but you know, there's always that kind of caveat in the use of kind of antifibrinolytics being like, oh, you know, it's DIC, it's a thrombohemorrhagic condition, so you know, don't use it in DIC. But I think as you're kind of maybe touching on, like as you said, it's not so kind of straightforward. Like DIC is a spectrum of you know, of a syndrome. I don't know if you say syndrome condition.
I think like the way I kind of think about it is that, okay, so DIC probably in the majority of patients is going to be due to like really severe inflammation or really severe trauma, but also like cancer can in itself express tissue factor. And like I kind of simplify it to myself that we have like, for whatever reason, expression of tissue factor that is diffuse or significant enough to activate clotting. And then clotting kind of happens, and like, you know, you're making clots, you're using up clotting factors, you're using up platelets, and then past a certain point you get to like a consumptive coagulopathy where you've really like used up an awful lot of your clotting factors and your platelets, and therefore you're actually then becoming at quite increased risk of hemorrhage. And then when you're bleeding, I suppose you could be bleeding because you're thrombocytopenic, or you could be bleeding because you've got clotting factor deficiency, or you could be bleeding because, as we said at the start of this talk, like when coagulation is activated, so is fibrinolysis at the same time. And so you imagine you've like diffusely activated coagulation throughout your entire body. You've also done that with fibrinolysis. And so if you get to a point where, you know, fibrinolysis has maybe like outrun coagulation, then you could be bleeding because that process is now kind of, you know, like run off down the hill, and you're breaking down fibrin all over the place, whereas you shouldn't be. So I think, like, I'm not sure if I explained that very well, but
yeah, no, I see what you mean, saying that you know, the bleeding doesn't just have to be consumptive of coagulation factors, the bleed, you know, and going back to the really important thing that I'd kind of not really fully kind of appreciated initially, is that fibrinolysis is activated, it's not after you form your clot, kind of at the same time. And so if that is happening in excess of the ability to form the clot, then the bleeding you see in sort of, you know, in part of DIC could be kind of a hyperfibrinolytic phenotype. Is that kind of what you're saying?
I think so. And I think it is really complicated. I guess, like, if you've got coagulation activated, then it is appropriate that you also have fibrinolysis activated at the same time. Like, that's a physiological response. But if you're activating coagulation throughout your entire body, and you're also concurrently doing that with fibrinolysis, then I think it would be like I think like we could probably all see a situation where actually fibrinolysis becomes like not sort of physiological anymore, and it's actually causing you problems because you've already started to develop a bit of a consumptive coagulopathy. So you don't have as many platelets as you should do, you don't have as many clotting factors as you should do, and now you have got widespread activation of fibrinolysis as well. So everything is like driving you to bleed, and not a lot of things are kind of stopping that. So yeah, I don't know, it is really complicated, and it does really depend on like all the balance of everything, but that's kind of like how I think about it. So when I'm thinking about if I want to give a fibrinolytic inhibitor, I totally get that if you've got a patient that is clotting and it's inappropriate, and they've got DIC and they're forming like little microvascular thrombi and they're affecting their tissue perfusion, then you don't want to inhibit a physiological response, which would be to break down those clots, because they're pathological clots. You want them gone. So I totally agree with that point. But then I think the thing that I find a bit more difficult is like, could you have DIC and still need to treat hyperfibrinolysis? I think you can. So because you have like the potential to have a DIC phenotype that is hyperfibrinolytic, whereas like, so you're actually, if you've got a DIC patient that's not bleeding, then yeah, don't give it any antifibrinolytics. But if you've got a DIC patient that's like actively bleeding, then you know what, like fibrinolysis and like tranexamic acid might be appropriate, because hyperfibrinolysis could be contributing to that hemorrhage.
Yeah, and I guess yeah, that really makes sense. But I think the difficulty is we always think it's really hard. It's very hard to assess if you're having like micro thrombus. How do we know? But as you were saying, if you're looking at your clinical picture, saying, well, actually, yes, if you're not bleeding and you're suspicious that the patient, based on various things that may have DIC, then yes, you're not going to reach for a drug that's going to stop your clots being broken down. But and those things, maybe they were like, I don't know, I had a patient recently where there's a sudden increase in creatinine, and it is the case that it's kind of risk of being kind of hypercoagulable. You're like, maybe you could buy there that it's having some kind of organ damage, because perhaps that, but we're just surmising because we don't know, like microthromby. But I guess what you're saying is, if they're hemorrhaging, like, just like you can't, like, how's going on, like hemorrhaging, I'm giving plasma. You're saying about the risk of giving a drug that will, stop excess fibrinolysis, what's the likelihood that you're going to cause thrombotic complications is probably pretty low. Is that what you kind of said?
And I think like this is where, like, for me, and I don't know, this is just like my opinion, but it has to be like clinically based. So if I've got a patient who has significant like clinical hemorrhage that I need to get under control, and yeah, maybe I suspect this patient may have a component of DIC, or like, and I've looked and, I can't do much about the platelets, but I'm treating the clotting factor deficiency, and like, maybe the PT and the APTT have normalized now, but the patient is still showing bleeding. Well, yeah, I would, at that point, I would reach for a lysine analog like tranexamic acid or aminocaproic acid, because I think if you can determine, like, if they're hyperfibrinolytic by running like a TEG or doing Rotem, then that's great. But we're not really sure like how useful those tests are all the time. And so I think sometimes like clinical picture and a risk benefit analysis, if they're bleeding, I would consider it for them. Yeah,
I guess we just kind of mentioned our tests, like how are we able to really reliably assess hyperfibrinolysis in that kind of emergency setting. And I guess we know, PT, APTT, like, no, it's not really taking that aspect into account. Blood smear, we're just looking, platelets, and I guess, you could say, oh, do we have some schistocytes or something like consistent with DIC? And then now we're moving, depends, I guess, where country in, whether you have a viscoelastic test, whether it's a TEG or Rotem. But what's been interesting, that's kind of, in institution at the RVC at the moment, we've got the VCM. So, there's kind of, bedside, viscoelastic tests, really quick and easy, to run. But I think I wrote a case report looking at detecting of hyperfibrinolysis on TEG in a dog with angiostrongylus. And it was only identified when we added TPA. And so I guess I always find that a bit tricky, because I'm like, okay, TPA, so tissue plasmin activator, activates your plasmin that breaks down like fibrin. And so if you're like adding it, then if you add too much, aren't you just going to induce it, yourself, like as an analytical error, rather than it's actually happening in the patient? And I just never know, like.
No, I get what you mean, and like I think I kind of sometimes like confuse myself and don't understand it either. But like, so how I think about it, and I don't know, like, I'm not saying this is definitely right, but I suppose in like these patients, like one of the things we're assessing is the body's ability to inhibit fibrinolysis. So like your alpha-2 antiplasmin, and your pi-1, which is plasminogen activator inhibitor. And so, like, if we compare, like, maybe two situations, so, like, let's say you've got a patient that's like a normal dog and they've got, like, no sort of excess or no hyperfibrinolysis, and they've got, like, an appropriate amount of fibrinolytic inhibitors, and there's not a lot of TPA release either. And so, like, you run a TEG for that dog and that looks like relatively normal, and then potentially you add a bit of TPA and you challenge them, and you might see, like, a bit of fibrinolysis, but then they've got, like, a suitable number of inhibitors, and so potentially, like, the degree of fibrinolysis is not that much because you've got these inhibitors that are present. But then let's say you have another patient that's just, like, experienced horrible trauma and has had really, like, widespread activation of fibrinolysis. They've had a lot of tissue plasminogen activator release, and they've actually had a lot of utilization of their inhibitors of fibrinolysis. So maybe they've only got, like, really low numbers of fibrinolytic inhibitors in their blood that are left in circulation. And so you run a TEG on that patient and you challenge them with the same amount of TPA, well, they're going to have a much greater response because they don't have as many inhibitors. I don't know if that makes sense. But
Yeah, I think, yeah, it's nice because I've never really, again, I've kind of gone a bit sort of linear in my thinking and been like, well, okay, if you give TPA, then you're activating the process. So, you know, surely if you give too much, then you're going to see it in all your animals. But the consideration that what you're saying, like, the way framing my question differently, or my thought process, that you're saying, no, you're just challenging the proteins that are going to prevent fibrinolysis, and, you know, if you have enough of them, then us giving you a bit of TPA shouldn't really tip you over the edge.
Yeah, I think so. It's like your capacity to cope with activation of fibrinolysis, essentially. And that might be different for different animals, depending on what their sort of balance of these inhibitors and activators is. So that's kind of like how I made sense of it myself, because I totally get your point that, like, we're assessing fibrinolysis, but, like, we're giving them an activator of it. So, like, what does that even mean? So I think that's why you've got to have controls, because you've got to have healthy dogs that have got, like, a normally balanced, you know, coagulation system. And you give them a bit of TPA and you assess what their coping mechanism with it is. You know, and they're fine, or, you know, like, you get a reference range for the lysis 30 and lysis 60, and you kind of say, okay, in most dogs with this amount of TPA, this is what the response is going to be.
Yeah.
Then you give it to a dog that's, like, you know, take a TEG sample for a dog that's, like, really sick and you're worried about their coagulation status, and you challenge them with a bit of TPA, and you see that they have, like, zero capacity to cope with it, and that TPA that you put into that sample sort of activates plasminogen to plasmin, and you get widespread, well, not widespread because it's within, like, a tiny little testing thing, but you know what I mean, you get, like, breakdown of fibrin in your clot, so you have, like, one of the, you know, the classic appearance of an increased lysis 30 and 60 on your TEG.
And do you think that so, and like you, I think you've highlighted important points, and that's why it's difficult with different studies, is looking at directly comparing, like, how much TPA did they add, like, what tests they're doing, because, you know, like you said, you need to be able to kind of compare like for like. So you can't say, well, these control dogs normally had dogs had a lysis of X, but if they, you know, if different concentration of TPA was added to the well, then you can't really compare it to the population that you're treating with a, you know, certain concentration of.
Yeah, I think it probably has to be, like, you have to create a little reference range for yourself.
Yeah. Do you think there's ever so in our kind of, you know, the like the bedside kind of test, we don't use like TPA as an activator. Do you think we can ever detect, like, hyperfibrinolysis on a non-TPA activated TEG, or do you think that you need the TPA to challenge the fibrinolytic proteins in the blood?
I can't, you know what, I can't remember, because I think I'm trying to, like, remember what the some of the studies and whether they've used TPA or not. I mean, I think you can see enhanced fibrinolysis without the addition of TPA, but I guess in my mind, like, that would probably have to mean that the patient was really you know, like had a lot of like TPA or UPA in that sample, and like not a lot of inhibitors available. So when you kind of activate coagulation with like calcium and you know, like your whatever you choose, like kaolin or whatever, to activate coagulation, then actually when that kind of occurs, and fibrinolysis is sort of activated concurrently with it, then it's not like inhibited. So I don't know. I think, you could see it. But it could be that you kind of, in a patient that perhaps is not as overt, then when you give them TPA, you kind of unmask the fact that they're like on a tipping point, you know?
I guess the other thing I remember when I was looking at my writing up my case report on that dog was that the viscoelastic test only runs for like set period of time. I guess like we're expecting fibrinolysis to occur at some point, but if it really occur in that time period that the trace is running for, like about half an hour? No, most of the time we don't really document normal physiological fibrinolysis on our test because we don't run them long enough.
Because that would be a nightmare if you like and then your body was like, no, I'm done like 30 minutes in. So
okay, that's really interesting. So I guess say for example we were in a situation where we had the ability to run a viscoelastic test with TPA added, and we documented fibrinolysis. I'd always be like, let's treat it. We documented, let's treat it. But I don't know if you saw kind of one of the abstract presentations, I think at EVEX, I think it was last year, where essentially they were sort of saying that they documented hyperfibonolysis in dogs with spontaneous hemperitoneum, and that kind of self-resolved following surgical control of hemorrhage and never actually needed antifibrinolytic therapy. And I thought it was kind of an interesting angle. Just because we see something doesn't mean that it needs intervention, and perhaps this may fit with what your discussion about kind of cavitary effusions earlier. But it'd be interesting to know what your thoughts on that.
I mean, I think again, like kind of you got to look at the clinical picture, and do you have like ongoing hemorrhage, or just sort of in those dogs, if they've got a cavity effusion, have they kind of got signs of systemic hyperfibrinolysis? And I don't think I would treat it only based on like my TEG sample necessarily. And I suppose, I don't know, like if they've had a sudden hemorrhage within like the preceding couple of hours, and you've removed the cavitary effusion, so you're not likely to have like more uptake of fibrinolytic factors. And also, like, I don't really know what the situation would be, but I'm kind of presuming at some point the liver will upregulate production of fibrinolytic inhibitors, maybe similarly to what we see in people that have had trauma. I don't know, like I think I don't know, I'm just kind of like hypothesizing on that, but I think I probably wouldn't if it was just a standalone lab test. I would kind of keep a close eye on the situation, but if they weren't like actively bleeding, then I don't think I would.
Because I guess we've got to think about it, haven't we? Dogs with spontaneous hemperitoneum, you've got to go in and do an explore, and in that sort of, like you said, you can kind of source control and can remove the cavitary fluid, and also kind of everything we give, like we've got to consider whether it be from fluids to drugs to surgery, like the cost benefit, and also the financial cost of things. And just because as you said, just because you wouldn't, like a blood work finding, you wouldn't always treat based on something you wouldn't go and stick every liver that had an increased ALT, so putting it in light of everything that you're the whole picture, and that kind of would kind of make sense what they were finding. And then you were saying about how look, the body does try and sort itself out, and in this case it happened. Yes, it kind of shifted in favor of fibrinolysis, liver kicked in, and the problem wasn't continuing. You kind of we use the kind of term from kind of sepsis, but you kind of controlled the source.
Yeah.
Didn't need further intervention. And I guess with our dog in our question, that the thing was it was just the dog just I thought it was super interesting when the surgeons said to us I find that they're always really oozy. It's something we can't really control, and then the fact that even post the second surgery, it wasn't found a bleeding vessel, end of, oops, it was still a really unstable dog. And I think based on our chat, I think I'm swaying to potentially empirically treating the dog with antifibrinolytic.
I think, yeah, sorry, go on, Laura.
No, so just...
I was going to say, I think I would do the same. I mean, when you were talking about the case, the kind of questions I was considering were, you said the dog hadn't been spayed. So, it's a Cocker Spaniel. Has it had any previous history of inappropriate hemorrhage for any reason? Is there a congenital coagulopathy here? I would probably also consider and I'm sure you guys did, but checking for angiostrongylus infection, lungworm, and then I think I would do exactly the same. I'll do a platelet count. We can't really do that much about it in the UK. Maybe some of our American colleagues have got access to more sort of platelet products, but and then I would treat the prolonged PT, APTT, and I guess your plasma is also part of is a useful resuscitation fluid in a hypovolemic dog, and whether that's consumptive because of DIC or it's just because of hemorrhage, or potentially if it didn't seem to have had that much fluids, but the effects of dilution of fluid resuscitation. And then I think if I was kind of doing all of those things, and I still felt my patient was bleeding and I had nothing left in my kind of artillery, then I think I would reach for tranexamic acid, having looked at all of those things that we just discussed, and particularly given that it had an adenocarcinoma, and it seemed to just be super oozy, and then there was no sort of definitive surgical cause of bleeding that could be found. So yeah, I'll probably do similar.
And I guess just to kind of end with thinking about you say, okay, right, I'm going to make the decision, I'm going to use antifibrinolytic, and then I guess it seems that you've got a preference, or I don't know if it's just availability for tranexamic acid. I always find it tricky. There's loads of varying doses, and what kind of dose do you use, say, of tranexamic acid? What route do you give it? Are there any particular concerns that we need to be aware of?
Yeah, so I think I've never used aminocaprylic acid. I think I've never had it. But yeah, certainly use tranexamic acid, and then so I normally will give them some meropitant beforehand, typically because it's a very good emetic, and so I usually sort of pre-medicate with meropitant and then give typically 15 milligrams per kilogram IV over sort of 20 minutes or so, just slowly, so that they don't feel so nauseous. And then you can repeat this sort of every 8 hours. Things in addition to nausea to kind of consider. So obviously vomiting would be contraindicated, and then any patient that was severely sort of stuporous or had a loss of gag, or had raised intraocular pressure or intracranial pressure, or potentially even a very high vagal tone, or if they're at increased risk of aspiration. We've discussed about DIC, and I think if you feel that your patient is going to be very prothrombotic and they're not showing a hemorrhagic phenotype, then hopefully you're not considering using tranexamic acid in them. But that does kind of raise
IMHAs.
Yeah, and it kind of raises the point of once your which is the next thing I was going to get onto, is once your hemorrhage has resolved, you need to stop the drug. So think about reevaluating very frequently. Okay, is it appropriate for this? Has my patient's coagulation status now evolved? This is dynamic, so is it okay to discontinue?
A fixed course. It's okay, they may need a few doses, maybe one, they may, but it's not once you start, just kind of blindly leave it on the kennel sheet. I think that's a really important point. Yeah.
And then like in sort of people like rapid, if you have aminocaproic acid, like rapid administration can be like most drugs, but can cause like hypotension and gastrointestinal signs. But then also there's reports of like weakness, myonecrosis, myoglobinuria, and rhabdomyolysis. So like I guess I don't have any experience of using that, but it's something to consider. And then sort of one of the other things I would sort of make you aware of is just be cautious when you're using a lysine analog in patients that maybe have like renal hemorrhage or potentially like bladder hemorrhage as well. The main thing is just to consider, like, if you get to a situation where you've inhibited clot breakdown, is that clot going to be like really problematic for you? So like you could potentially, I think there's a report in people of a ureteric obstruction. So just kind of be aware of that and consider it. And I think in cats, like they've done some horrible experimental studies where they've put like tranexamic acid on the brain and they seizured, and I'm not really surprised that they seizured. Technically, therefore, like seizuring is like listed as a potential complication. But I think like at the dosages we're using, and if you're not using them like intracerebrally, I think you'll be fine. And yeah, and I think
I think I've heard maybe like a clinical report of seizure posted in, I don't know whether I read it somewhere about a person post cardiac bypass or something, and I remember being interested in it because I thought, is it something to do with its effect on like GABA or something? I just remember being, oh, that's quite interesting, that maybe it has some sort of effects on the neurotransmission.
That does ring a bell, Laura, but I can't remember what that was about specifically, but you might be right about that.
But like you said, I think it, you know, I mean, I've never, I guess, yeah, I've seen vomiting, and I think that's a really important point. I think there was a recent maybe JVEC study. I'll have a look, see if I can dig it out. Like,
I'm just reading I'm reading my review article because I'm just checking myself, but I've written that tranexamic acid is associated with seizure activity secondary to inhibition of GABA A receptors and glycine receptors, which are obviously like the major inhibitory neurotransmitters. So I think that's the proposed mechanism. The only other thing I was just going to mention is like it can, both tranexamic acid and aminocaproic acid are primarily renally excreted, and so in people with renal impairment, they do recommend a dose reduction, but they don't really have like specific guidelines. They just say give less. So I think just consider that as well, if you have a veterinary patient with renal impairment.
Yeah, that's been wow, we've really rattled through like nearly an hour of talking, Rachel. We thought it'd be half an hour, but no, it's been a really really interesting topic, and it's been really great to hear your thoughts. If you don't mind, can I like link your review paper to the show notes?
Yeah, of course.
So then the listeners who wish to do some further reading and check you for further information, they can have a look at that.
Yeah, absolutely. And like, I mean, feel free to like fact check me as well on things, but hopefully most of it's kind of included in there and referenced, so hopefully we're good.
Yeah, I think it was really nice, really kind of logical, clinically relevant talk through the case, has really kind of helped me reflect on that case and sort of consider how what I may manage differently in the future. So I'm very grateful. Yeah, it really did, and I think that I hope all the listeners will find it helpful as well.
Cool.
Thanks so much.
No, you're very welcome. Bye.
Bye.